Thank you for joining us for our lunchtime webinar. My name is Karen Shaw, and I am a member of the Alumni Affairs Office in the Fielding School of Public Health. What we hope to do with this program is to open the classroom, to give you a refresher course on the latest research and thinking on critical public health issues, and to hear from those of you practicing public health. We want to be in a dialogue with you, our graduates and friends, so this will be a 30-minute lecture followed by 30 minutes of questions and discussion. For those of you that just joined, please set up your audio by going to Tools, Audio, and then Audio Setup Wizard. If you are all set with your audio, please use this time to edit your profile. Simply right-click on your name and fill out the small form with your name and contact information. Also, please feel free to give us feedback using the emoticons right underneath your name. You will be able to ask questions by typing them in the chat box on the lower left-hand portion of your screen. You can type them as they come up during the lecture or wait until the question and answer part of the webinar. Our lecturer today is Dr. Dylan Roby. He's Director of Health Economics and Evaluation Research at the UCLA Center for Health Policy Research and Assistant Professor of Health Services at the UCLA Fielding School of Public Health. Prior to joining the faculty at UCLA, Roby worked for 5 years as a senior researcher at the UCLA Center for Health Policy Research and for 4 years as a senior research associate at the George Washington University Center for Health Services Research and Policy. Today, he will be talking to us about opportunities for innovation in Medi-Cal and California's Medicaid waiver. Dr. Roby?
Thanks, Karen. I'm happy to join everyone. Thanks for attending the session. So today we're going to be talking a bit about the recent renewal of California's Medicaid 1115 demonstration waiver, which has kind of been converted from a safety net financing waiver to something a little bit more broad. And so we'll cover the 4 different programs that are really created through the waiver and discuss a little bit about the implications of the waiver for future planning in California around healthcare reform, as well as the potential that the waiver has, especially in the safety net for delivery redesign and changes to the California healthcare system. So first I want to start out with a little bit of background. As many of you are aware, the federal Medicaid and Medicare law, the Social Security Act that started everything in 1965, allows for waivers by states of specific requirements of federal law. And it's done through several different mechanisms. Often we hear about 1913 or 1931 B and C waivers, 1915 waivers, which allowed for home and community-based services as well as managed care delivery. In this case, we have an 1115 waiver, which is considered a demonstration project that we have 5 years of approval to conduct within the state of California around Medicaid. And the precursor to this was a separate safety net care financing waiver that was renewed and turned into this waiver that existed from 2005 to 2010. So in November of 2010, after negotiations completed in the renewal of the waiver, CMS approved what's called the Bridge to Reform 1115 waiver to California's Medi-Cal program, and it really expands and renews the previous safety net care financing waiver and provides an additional $10 billion in federal funds over 5 years. Previous to a few weeks ago, this was a pretty sizable amount of money. However, recently we just found out that I believe Texas has just received approval for about a $29 billion waiver to do similar things in Texas that really focus on coordination of care between safety net hospitals as well as nonprofit and private for-profit hospitals in the state. So while it's smaller than the Texas waiver, it still brings a substantial amount of federal investment into the state prior to healthcare reform, when I think a lot of these changes are needed to move Medicaid in the right direction before we experience this massive expansion potentially in 2014. So the approach taken in the waiver was determined through a pretty expansive stakeholder process that really culminated in the passage of AB 342 and SB 208, which gave authority to California Department of Healthcare Services to negotiate this waiver with CMS based on some pretty primary tenets, some of which ended up staying in the waiver proposal, some of which were taken out when we got to the finalization of the waiver. So initially the waiver was supposed to include elements around coordinating care for dual eligible populations, dealing with mental health integration, and a lot of those were taken out of the waiver during the negotiation process, either due to political reasons, to monetary reasons, or because CMS felt like they were going to address it through other programs. So the dual eligible portion of the waiver, for example, was taken out, not because CMS wasn't interested in dealing with coordination of care for dual eligibles and the cost there, but because the CMS Innovation Center has actually taken on that task separately and has been coordinating state efforts around dual eligibles in a separate process. Later on, AB 1628 was used to add on corrections to the waiver, and we ended up in implementation phase in late 2010 and even now. And so first we have the main components of the waiver, which I'll touch on separately. One is a Medi-Cal managed care transition that will actually move almost 400,000 seniors and persons with disabilities, or the SPDs as they're commonly called, into 14 urban areas that already have existing managed care systems in place, either a two-plan model like LA with HealthNet and LA Care, or a geographic managed care model. The assumption is that the county-operated health systems that operate like CalOptima are already doing SPD management of services and payment through managed care through their county-operated health system. Second, we have the California Children's Services Pilots, the CCS Pilots, and they really focus on creating innovation in the CCS program, which is a carve-out program dealing with children with special health care needs. Third, we have the Low-Income Health Program, or the LIP, and it really focuses on a temporary expansion of access to the low-income uninsured. And it's kind of California's answer to early expansion of Medicaid in response to the ACA. We've had some states like Connecticut expand early to the 0 to 133% of poverty level population in preparation for ACA implementation January 1st, 2014, and take advantage of matching dollars. But California wasn't able to do that. Instead, they negotiated the Low-Income Health Program, which fills in the gap a little bit prior to Medicaid expansion in 2014. And then we have the Delivery System Reform Incentive Payments, affectionately called DSRIP, which really focuses on using the safety net care financing pool dollars to generate innovation within university and public hospitals in the state of California. So there's some common themes that kind of run across the waiver, and I think these are the same themes we see run across the Affordable Care Act as well, with issues of cost, quality, and access really driving the discussion. So we do see delivery, redesign, and innovation that not only occurs in the public hospital DSRIP program, but also in the Low-Income Health Program, also in the assignment of beneficiaries in Medi-Cal managed care. And so there is a focus on creation of medical homes and coordination of care, regardless of which component of the waiver you're talking about. In addition, we have access to care changes that run through all aspects. With these improvements to the safety net that should, in effect, improve quality of care for people currently in the safety net, whether they're uninsured in the low-income health programs or in Medi-Cal already, or even in private coverage if they are going to a safety net hospital, but also running into trying to expand the capacity of public hospitals, of safety net clinics like community health centers, to expand the ability to provide care in preparation for 2014. And expanding access early potentially has the positive result of having some of the pent-up demand currently faced by the uninsured population, where people have been delaying care due to cost or other barriers, where they would now be able to access care prior to 2014. So when Medi-Cal expands fully in 2014, that some of that burden could be taken off of the shoulders of county safety net systems. There's also enhanced benefits and coverage for the uninsured through these county indigent care programs. As many of you are aware, Welfare Institutions Code Section 17,000 in the state of California basically says counties are the provider of last resort, and they really are responsible for caring for the indigent. And counties have done that through a patchwork of funding over the years, and this represents a way to get the counties to have a significant amount of investment where half of the dollars are coming from federal sources for this core part of their patient population that allows them to invest in infrastructure, invest in health IT, invest in coordination of care, and using support staff to try to guide indigent patients through the system a bit better and provide better benefits. Lastly, we have this cost issue. So we do see some elements of payment reform in the waiver, ranging from the CCS pilots that have the ability to innovate, whether it be through an accountable care organization model or in the DSRIP program where there's the potential for using a global payment system. So use of new reimbursement methods, whether it be capitation related, ACO related, or simply changing the way in which partners in a network are paid, potentially have impacts in the future of healthcare reform as well. So first I want to detail the managed care aspect of the waiver. So managed care has been a pretty substantial part of California's Medi-Cal program since the mid-90s, but typically it's been focused on mothers and parents and children in the considered the TANF population, the temporary assistance for needy families population, which tends to be a little bit lower acuity, a healthier population with fewer healthcare needs in general, whereas the seniors and persons with disabilities, depending on the county, have really been moved in, or were really pushed into fee-for-service and stayed in fee-for-service. So in a county like LA, we basically had an even split between the healthier Medicaid managed care population and the sicker fee-for-service SPD population. In counties like Orange, where CalOptima developed and we have a county-operated health system, all of those services have been managed for both populations through their existing CalOptima program. And so the idea is that if we move to a more coordinated system through a managed care firm, we're able to both improve quality and patient satisfaction and also save costs, because the rates negotiated put a lot of that risk on the managed care plans to better coordinate care. So in areas with current managed care options, geographic managed care or two-plan models, so those 14 counties I mentioned before, which include Los Angeles, Alameda, other urban counties for the most part, are really representing the 380,000 people that will be eligible for this mandatory move into managed care. And the move started occurring in June 1st of 2011 and was based on birth date, so that people born during the month of June would be transitioned into the managed care plan from fee-for-service during that month. And then people born in July would get enrolled in July. People do have the option of opting in early and choosing to enroll in a managed care plan proactively. In addition, any new eligible into Medi-Cal who gains eligibility and enrollment would automatically be put into a managed care plan where they would never see fee-for-service. Medi-Cal beneficiaries in rural areas and those who are dually eligible will continue in fee-for-service. So there's still a sizable part of the Medi-Cal population that will be in the fee-for-service program, but most of the urban residents will be now in managed care plans in a geographic or two-plan model county. So really these are the full scope aid codes considered the seniors and persons with disability, and it excludes the dual eligibles, or those who have Medicare, foster children, people who are identified as long-term care participants, those with other health insurance if they have Medi-Cal as a secondary coverage, anyone with share of cost Medi-Cal, and then anyone who's in the California Children's Services pilot areas. But this is really an attempt to control costs and improve care coordination across the board in these 14 urban counties. So next I wanted to touch on the California Children's Services Program, which is a program that has almost 200,000 children in it, and some young adults. You can qualify up to age 21 due to a specific condition, typically a chronic condition or potentially disabling condition. The current program runs on what's called a carve-out approach, in that there are managed care providers doing business in CCS counties that will take care of primary care services, some specialty services that are covered by the managed care network, but then some other services that are CCS covered need to be delivered through the CCS certified facilities, including specialty care centers and actual hospitals. So the costs tend to be fairly high because of the type of population you're dealing with these 200,000 special healthcare needs children who have disabling conditions and very high cost conditions. About over 1/3 of the spending is actually on the infant population, and almost 2/3 of the entire CCS budget is spent on inpatient hospital care. And historically there have been problems with coordinating services and benefits between the managed care plan that gets assigned the patient and then the CCS facilities that often end up having the patient for a long period of time and not being able to provide primary care style services to the patient population. You often hear stories about people who, or providers who deliver a service and they're not sure who should be paying for the service, and they'll basically see who's going to raise their hand and pay the bill. And so often CCS raises their hand and pays the bill, and managed care plans may not be subject to paying for services that should have been delivered under a contract for their patient. So there's been concern about abuse of this dynamic and waste and duplication of services because sources of payment are coming from two different entities, even though they're all a Medi-Cal population, and with some coordination with Healthy Families and other private insurers. So the broad goals for these CCS pilot sites, which I'll cover in a second, that were identified in both the waiver proposal as well as the request for proposals to recruit these pilot sites to actually participate in this innovation approach, is to improve care coordination, improve quality of care, reduce the rate of growth in spending, and also change the distribution of the mix of services. So the hope would be that we would see a reduction in the use of ER and inpatient services, an increased use of community-based services, and outpatient primary care and specialty care. Improvement in the value or cost effectiveness of care, as well as an improvement in patient and family satisfaction and more of a patient-centered approach, a culturally competent approach to dealing with these 200,000 children and their families. Also, an increase in satisfaction with the delivery and reimbursement among providers is a key component that was included in both the waiver and the RFP, which really shows how the state feels about this program and how stakeholders feel about the program. I think many providers, if you talk to a CCS provider, will say that it's a population that really needs help. They really need a good quality of care, and they really focus on a patient-centered approach, but they feel that the reimbursement rates are too low, or that they're not able to be paid for services that are really necessary for the type of patient they're trying to manage. And so the pilots potentially create this ability for expansion of services that could be delivered that wouldn't typically be paid for under a fee-for-service mechanism. If you have an accountable care organization style environment where you could hire community health workers and interpreters that can't bill for services in a traditional fee-for-service model, but could be paid through this overarching umbrella of an ACO, it kind of enables the site to take on additional services that wouldn't typically be delivered through fee-for-service. So there are 5 different CCS pilot models that were chosen through the Department of Healthcare Services request for proposals process. All of them are in various stages of negotiation with the state around payment and the contract, and all of them are expected to go live as operating CCS pilots, hopefully in the summer of 2012. They vary in terms of the approach that they take to managing the CCS population. It's not necessarily that everyone is going to engage in the same type of intervention to manage the CCS population and all the complications that arise from that from a resource standpoint as well as a clinical standpoint. So Alameda County is going to be running what's called an EPCCM, an Enhanced Primary Care Case Management Pilot. They're expecting about 5,000 enrollees across all of the CCS eligibles within the county. They're asking for mandatory enrollment of all CCS eligibles into that pilot. So anyone living in Alameda in CCS who's eligible for CCS would be moved into this Enhanced Primary Care Case Management environment run by Alameda County. In San Diego and Orange, they decided to go a different way, which is to create an accountable care organization pilot, but both of them limited their patient population to specific CCS eligible health conditions that they felt they could have a main impact with. So San Diego Rady Children's Hospital has about 300 children that they're expecting to enroll in a somewhat slimmed down project with just cystic fibrosis, sickle cell, and diabetes covered as those specific eligible health conditions. Whereas Orange is estimating about 5,300 enrollees, and they also have disease-specific criteria, but they've chosen 10 diseases that are pretty broad in nature, and so probably represent a majority of the CCS population in the county, and that'll be run by Children's Hospital Orange County, or CHOP. The fourth pilot, LA Care, the Los Angeles pilot, is actually a specialty healthcare plan approach where they're joining forces with Children's Hospital LA as well as UCLA Mattel Children's Hospital. And it's somewhat of a hybrid approach, so it doesn't really fit into the ACO model or the HMO model specifically, but it kind of represents all three of the options, where this hybrid model will use some of the ACO elements for certain providers and the health plan elements for others. And they expect to care for about 6,200 beneficiaries in LA, and they're actually choosing specific zip codes that they can deal with, and other zip codes in LA area wouldn't be subject to the CCS pilot. They would just be subject to the typical CCS fee-for-service mechanisms. And then the fifth is San Mateo Health Plan, the Health Plan of San Mateo, with about 1,800 enrollees, and they're using an existing Medi-Cal managed care plan model using their county-operated health system health plan as the major coordinator of care there. So you can see that, the CCS pilots could potentially tell us or provide some lessons to how we should actually manage the CCS population in the future. And the answer may not be managed care for everyone, because we're not sure how it'll work in terms of bridging this gap between fee-for-service and managed care. But we could see that an ACO or primary care case management approach, where you do have a little bit more flexibility in terms of billing, would allow for better coordination of care, improved patient satisfaction, family-centered approaches to care, and also this better satisfaction for providers in terms of dealing with care and providing it. So next we have the Low Income Health Program, or the LIP, and this is a program that is really a non-Medi-Cal program. So the previous two, I was really focusing on people who are already eligible for Medi-Cal but are maybe not getting the level of care they should get, or they're costing too much money from a budget standpoint. In this case, the low-income health program is really an expansion of this population that's eligible for Medi-Cal type services and are eligible for federal match under this waiver. So there's significant funding for county indigent care programs, and this is really an expansion of the previous waiver, which allowed for 10 counties, which are now called the legacy counties, to enroll people from 0 to 200% of federal poverty level who are 19 to 64, were not otherwise eligible for Medi-Cal, and were either a legal permanent resident for more than 5 years or a U.S. citizen. So really the federal guideline around Deficit Reduction Act requirements for eligibility. And it enabled these 10 counties to draw down 50% match on certified public expenditures they spent on caring for an indigent population that actually isn't eligible for the California Medi-Cal program, but based on income would be eligible in 2014 for exchange subsidies up to 200% of FPL, or for the Medi-Cal expansion up to 133% of FPL, once we remove this issue of categorical eligibility, where only disabled, medically needy, and people with children are eligible in the adult population for Medi-Cal. So the main focus is creating these two new programs to enroll and provide coverage for the Medicaid expansion population, 0 to 133% of FPL, and what's called the Coverage Initiative, or CI, which is 134 to 200% of FPL in each county that chooses to engage in the program. So the LIP is expected to enroll about 500,000 people statewide over the period of time from November 2010, when it was implemented, to, or when some of the counties implemented, to January 1st, 2014, when it ends and Medi-Cal expansion begins. About 2 million plus Californians are estimated to be eligible for Medi-Cal in 2014. Of course, depending on who you're listening to, the number of people who will actually enroll could range from 1 million all the way up to 1.6 million or so, where we expect certain members of the population to take up more actively the Medi-Cal options that will be available to them in 2014 in a very low-cost option for staying insured. So these 500,000 people put a dent in that upwards of 2 million people who will be eligible, but it's a sizable number of people that California could probably count on, as long as they do an effective job of transition planning, to draw down 100% federal match, as they'll be allowed to do under the ACA in 2014 and beyond. So the LIP really is, it's up to the county to create a program, start enrolling people, and to set the eligibility thresholds and criteria. So we have these 10 legacy counties: Los Angeles, Alameda, Contra Costa, Ventura, San Francisco, that already have an existing HCCI population, which is the old program from 0 to 200% of FPL. They then had the choice to create a new program and split them into the Medicaid expansion and the HCCI programs, and either continue with those eligibility criteria or create a new one. And so some of the counties have maintained the eligibility criteria, like Alameda, and they actually expanded from a program focused on diabetes and hypertension up to a program that included everyone across the board just based on income. So Alameda has a Medicaid expansion program up to 133% of federal poverty level, and they've continued their HCCI program up to 200% of FPL. On the other hand, a county like Kern has had to deal with limited budget issues and went from having a legacy program that was 133% of federal poverty level down to a program that now just enrolls people up to 100% of federal poverty level, and no longer enrolls new eligibles into the CI program because they no longer cover up to 200% of FPL. So depending on county budget situations and for planning purposes, some of the counties have created programs that go all the way up to the 200% of FPL level, and some have reined in the program a little bit and used a lower eligibility threshold. So Santa Clara goes up to 75% of FPL. Sacramento, which hasn't implemented yet, goes up to 67% of FPL. Riverside just implemented recently, and they chose to go up to 133% of FPL. So depending on what county you're in, an uninsured person could have a differential ability to actually enroll in the program and take advantage of the LIPs. However, as time goes on and the populations start to be managed by the LIPs, it's very possible that the new counties and the legacy counties could start ratcheting up the eligibility if they have the budget to support it and the resources to support it. One of the large members of the LIP group will be CMSP, the County Medical Services Program, which represents about 34 rural counties and coordinates indigent care for them. And so the new group, CMSP, Santa Cruz, San Bernardino, and Riverside, which is currently, they're all currently live and enrolling, could add about 70,000 people to the already 250,000 plus enrollment in the LIP project. So we've already hit about half of the potential eligibles who we expected to enroll actually enrolling in one of these 14 local programs. So, the LIP isn't just a payment mechanism, it's also a way for counties to develop better systems of care. And so one way to do this is to provide medical homes to many uninsured individuals prior to 2014, and of course, with the 50% federal dollars coming in, it enables enhanced payment to certain providers and to build relationships that maybe didn't exist before in a specific county. In a county that used to just rely on county hospitals and county-owned clinics to do indigent care for people who came in, and then there was a separate safety net that existed in the private nonprofit world with federally qualified health centers that didn't really integrate care together, have now been encouraged in essence by this program to join forces and negotiate networks that would kind of meet the coverage needs of this population. And while they don't look like the Medi-Cal network, they come pretty close in certain examples, and there are elements to make sure there's network capacity to deal with the uninsured population in these areas. And I think, we've heard folks in LA County, Mitch Katz specifically, say that LA County's safety net has been very criticized for access to care, for quality issues over the years, and to prepare for 2014, it's really imperative on the county systems to become providers of choice rather than the providers of last resort, as has grown out of the Welfare and Institutions Code. Because in 2014, if we have Medi-Cal managed care and exchanges that are operating well, that cover people who are under 400% of poverty level and get subsidies, it'll be important for these county facilities that might be losing quite a few patients to insurance that they used to take care of in more of an uninsured, uncompensated care environment, or a county dollars-based provider system, that they will now have to compete for those patients by becoming part of managed care networks, becoming a provider of choice in the new world of health reform. So I think it's an important aspect where the LIPs actually are getting some of these resources that could enable them to do that and really coordinate care well for these 500,000 people that are estimated to enroll over the next few years, so that those patients don't necessarily want to leave when they hit 2014 and they have access to Medi-Cal managed care or exchange-based subsidies, where they'll actually seek out health plans that are contracted with the provider that they've been introduced to and is managing their care during the LIP programs. So as I mentioned, the LIPs look a little bit different than the original coverage initiative. So the LIPs first have to go up to 133% of federal poverty level, and the benefits package looks a little bit more like Medi-Cal, has more extensive benefits. There are cost-sharing limitations that look very much like Medi-Cal, and federal matching, like Medi-Cal, is not capped because it's a mandatory part of the federal budget. LIPs, however, aren't required to pay on the Medi-Cal fee schedule, so in some counties you see that providers, especially private providers in areas, will be able to get a higher fee than they would have gotten in Medi-Cal under the LIP. The benefit package is a little bit more flexible for 134 to 200% of FPL under the CI. They're not subject to the same protections that the Medi-Cal population is, and there is a capped federal allotment of about $540 million over the program, and it tends to be a little bit more risky for counties because of that capped federal allotment. If a county overshoots their eligibility predictions and they enroll everybody up to 200% of FPL in their county, they could blow their county budget, and because there wouldn't be federal dollars there to match it, they could face that risk. So I think that's why you've seen some of the counties be a little bit more cautious in terms of the FPL level they're willing to cover early on, and they'll see how things work out, and then potentially expand it later. So lastly, I wanted to cover the DSRIP project, which is focused on innovating in public and teaching hospitals in the state of California. And so it's more flexible than the previous waiver in terms of safety net hospital funding. The previous waiver really focused on transitioning us from an intergovernmental transfer DISH program to more of a certified public expenditure-based DISH program, and didn't really focus as much on experimentation with different payment methodologies. The real experiment in that waiver tended to be around the healthcare coverage initiative part of the component of the waiver. But now we have what's called the delivery system reform pool, which is about $3.3 billion that are being divvied up to different hospital systems. And you'll often see them the DSRIP program referred to as years 6 through 10 of the waiver, because the safety net care financing waiver, which provided the basis for this renewal, are considered the years 1 through 5. So right now we're in year 6 of the DSRIP program, in that these county and university hospitals that are eligible are, like UCLA, like Alameda County Medical Center, like UC Irvine, are putting together plans to invest in infrastructure, invest in innovative care delivery models, focus on population-based improvement for chronic conditions, and also develop hospital-specific interventions around patient safety, and making measurable improvements in the short term, in the next 5 years of the program. Also, there's an element on top of these quality and infrastructure investments in innovating in terms of payment. So in the waiver, DHCS suggested taking advantage of some of the provisions of the ACA and creating a global payment pilot program, which would allow for the state to pay on a capitated basis for Medi-Cal beneficiaries cared for by hospital systems rather than reimbursing using the typical agreed upon amount or the CMAQ rate that's negotiated every few years for many hospitals, especially including university hospitals, that might be based on a per diem rate rather than a more global risk-based rate. And I think this is important to underscore because we are moving from a per diem rate to the contracted Medi-Cal hospitals that are non-public to a DRG-based rate in the next year or so. It's slated to start July 1st, 2012, but there's some speculation as to whether that would actually happen. And if you're moving from a per diem rate to a DRG rate, there is a lot more risk placed upon the inpatient facility to manage care in an effective and more efficient manner. So the innovations that are being done through the district program are based on what the hospital actually wants to do. So if you look on the DHCS website, you'll see that each hospital has submitted a plan and a proposal to DHCS for approval that talks about the different programs they'll be implementing. Some of them look very similar to each other, but some look very different. So Alameda, for example, Alameda County Medical Center has really focused on expanding primary care capacity, implementing and utilizing a disease management registry functionality within their hospitals and their clinic system, expanding specialty care capacity. On the innovation side, they're expanding medical homes and improving chronic care management, trying to improve patient flow in their emergency room. They're doing care coordination programs within their ACS ambulatory care sensitive population to reduce readmissions, and they're focusing on preventive care around mammography, flu, vaccine, things like that. And then they picked out these urgent improvement programs over the next 5 years that will focus on central line infections, surgical site infections, pressure ulcers. So they're designing these, continuous quality improvement efforts with this investment coming from the delivery system reform pool. UCLA is engaged in similar innovations, but they've done it somewhat differently. So pediatric medical homes are a key component of the district funding coming through UCLA, but they've also focused on things like surgical complication care processes, medication management, expanding through primary care with Venice Family Clinic, but they also have these broader coordination of care goals that look very similar across the other district hospitals. So each hospital put in a plan. Some of them share commonalities that would allow us to look broadly at all the different hospitals participating and see what's working, whereas others are very focused on developing a model of care or system for specific issues within a hospital that's been a pressing issue. So I think all four programs represent somewhat separate programs that really share a lot in common, I would say. I think in terms of opportunities for improvement, we can learn quite a few lessons for delivery systems that have a large uncompensated care and Medi-Cal caseload. I mean, in the ACA, we see lots of money potentially flowing to accountable care organizations through the Medicare program, but typically hospitals that deal with lots of Medicare patients and have these private networks that are going to take advantage of the ACO pilots may not be safety net hospitals, and safety net hospitals like Alameda or Harbor UCLA may have a very tough time making money off of the ACO model because the core of their patient population is either Medi-Cal or uncompensated care. So creating this integration and these incentives in county and university hospitals is a pretty interesting way to go about it, and it's outside of the ACA, but it certainly could have impacts on saving money in the future and developing coordination and allowing these safety net facilities to become providers of choice rather than providers of last resort. Coordination of care is a common theme that runs through all of the different aspects of the program, whether it's the managed care firms that are getting SPD patients and need to assign them to a medical home, to the CCS pilots who have decided we already have to coordinate care with managed care PCPs, but there's no reason why our patient population may not have a medical home that's specialty care related, and we may see something like that at UCLA. To the district program where the pediatric medical homes could be targeted, or specialty care integration with medical home PCPs, and then the LIP, where everybody who's enrolled in the LIP has to be assigned to a medical home and have a common place where their medical records reside, and there's an effort to coordinate care between specialists that they're referred to, the patients are referred to from the PCP, and attempts to integrate IT systems better. I think one other big aspect that is helpful in preparation for 2014 is this issue of getting to people relatively early, and the fact that 25% of the Medi-Cal eligible population in 2014 could very well come from the low-income health programs. And so if counties in the state do a good job of transitioning those patients, they have people who don't have a break-in service, they get seamlessly transitioned into Medi-Cal in 2014, and you don't end up with dealing with new issues of pent-up demand for that portion of the population. So you really only have to deal with any shortcomings in provider capacity and pent-up demand in the new eligible population, which is probably less likely to use services immediately, and we may see more of a gradual transition into Medi-Cal expansion rather than flipping the switch and having a bunch of people show up in the program immediately. So it could improve appropriateness of care and service use if people are assigned into medical homes and know they need to go to a PCP rather than showing up at the ER for primary care services. That's a step in the right direction, especially in safety net populations where we do see ER overcrowding and coordination of care issues because of the way people seek out care. I think it's also important, considering that the focus of all of these programs is in the safety net and developing the ability for them to provide care to the new Medi-Cal population, the new exchange population, that disproportionate share hospital funding will be cut substantially by the ACA, where from 2014 through 2020, there's an $18.1 billion cut on the table for DSH, where it's going to be reduced quite substantially, with the assumption that these hospitals are now going to have paying patients coming through the door through Medi-Cal and the exchanges, rather than needing to subsidize care for the uncompensated population. So I think it'll be really important for public hospitals to take advantage of the opportunities to be able to retain these patients rather than lose them to the private market, because they will need to absorb these DSH cuts. And I think no public hospitals want to be the magnet for everybody who continues to be left out of the system, who don't sign up for Medi-Cal, don't sign up for exchanges, or aren't eligible for them. So, and to leave it at that, I think now we'll address any questions you have. Feel free to contact me directly if you do, but I think Karen Shaw will now lead the question and answer session.
Thank you, Dylan. We have about 15 minutes for questions. Simply type your question in the field at the bottom of the chat window. And please type only one question and wait with your next question until the first one is answered. We want to make sure that as many as possible can be engaged in the discussion. While you are typing your questions, I wanted to point your attention to what Eric posted earlier. If you missed part of this webinar, or if you are interested in any of our previous webinars, just go to the Fielding School of Public Health website. They are all archived there. Please allow a few days for this one to be posted. I see there are no questions yet, so let me ask a question. Dylan, how do these waiver programs complement or replace the efforts and delivery system changes due to healthcare reform?
I think, I discussed it a little bit before, but I think that the waiver potentially enables the state to do things early when they can't really rely on, due to political reasons or due to budget reasons, to expand Medi-Cal early. So as I mentioned, Connecticut and other states have decided, well, now all we have to do is issue a state plan amendment due to the ACA and expand our Medi-Cal program up to 100, or Medicaid program up to 133% of FPL. And some states have decided to do that. And California, of course, has the option to do that as well. But because counties are spending so much money on indigent care for this population already, it seemed a little bit smarter for the state to pursue getting those people in to systems through the waiver because they can leverage the county funds that are already being spent rather than spending general fund dollars because only half of the money is coming from the feds. In 2014, of course, 100% of the money will come from the federal government from 2014 to 2016, and then it'll be scaled down so that new Medicaid eligibles will be paying 90% federal dollars, in essence, by 2020, and that would continue on. So it's just a way of getting people into the system and then hopefully taking advantage of the additional federal matching that'll be available in the future.
Thank you for clarifying. That's very helpful. And how are counties able to afford the costs of these innovations given the pressures on local government budgets?
I think the matching funds is helpful, but I think they kind of have to do a cost-benefit analysis, and that's probably why you see counties not expanding their entire program quickly. So if they're able to quickly set up programs that will keep people out of the ER and will end up sending them into the medical home that they've been assigned to, and make sure that coordination of care occurs where the medical home actually has a place to refer this technically uninsured patient, but someone who now has access to services into a specialty provider at a nearby county specialty clinic or at a hospital system. That's far better than the alternative, which is have somebody show up in the ER, have somebody show up in urgent care, need to go to a specialist but not be able to get a referral and end up sitting in the ER for hours in order to see that specialist, even if they don't have an emergent condition. So hopefully it'll make services more efficient. In the short term, full disclosure, the UCLA Center for Health Policy Research has been engaged in doing the Healthcare Coverage Initiative evaluation and now the Low-Income Health Program evaluation. But you see a bit of an early hump in health services use, where as soon as people get coverage through the LIPS or the HCCI, they used more services, got caught up, and then they end up, you see a decline in services overall. So a year out, 18 months out, their services have leveled out a bit more, and you don't end up with these high expense episodic service delivery issues where you pay a lot of, the county has to pay a lot of money. You end up paying some up front, getting matching funds, and then leveling out and dealing with those demand issues later on. So I think the matching funds certainly make it helpful, or are certainly helpful to the counties, and it's pretty imperative that the matching funds come in. I don't think counties could do this on their own by creating better working systems and just it would result in lots of people using services that stay unreimbursed and that the county then has to pick up.
Thank you. And I see we have a question. Will benefits under Medi-Cal expansion be the same as under LIP MCE after 2014?
I don't believe so. So the LIP MCE benefits are a little bit abbreviated versus the typical Medi-Cal benefit package. And it looks like the Medi-Cal expansion benefit package will be limited compared to the current Medi-Cal benefit package. So in the ACA, it actually says that the Medi-Cal expansion programs could have a different benefit package than the existing Medi-Cal programs that have been designed previously. And it should, in theory, be pegged to the Essential Health Benefits package, which is being determined by Department of Health and Human Services with help from the National Association of Insurance Commissioners. But as many of you know who have been following ACA implementation, the NAIC and the HHS basically didn't actually come out with the regulation. They came out with a bulletin providing guidance that states should pick a benefit package that looks pretty typical among their largest health plans that are doing business. So you may end up seeing Medi-Cal look a lot more like a commercial insurance product in terms of benefits, even though the cost will be lower. So it's not yet apparent how the LIP MCE benefits compare to the current, or will compare to the future Medi-Cal expansion benefits, and they actually could be less generous.
Thank you. And then we have another question from Helen. Are there provisions for shared learning in a timely manner about effective strategies across the county, such as QI, payment reforms, care models, etc.?
Yes, so there's some of that. I think, CAPH, the California Association of Public Hospitals, has been pretty involved in getting their member hospitals that are part of the district program to engage in these collaborative efforts around learning from each other. In addition, as part of the evaluation for the low-income health program, which UCLA and UC Berkeley are doing, funded by the Blue Shield of California Foundation and the California Medicaid Research Institute, we're creating these convening meetings that occur yearly, as well as webinars that will occur every 6 months around innovations in enrollment strategies, innovations in quality improvement, and coordination of care. So we do bring the counties together to share their experience with each other. We think that's been a pretty helpful strategy thus far. Right now, because a lot of them are in implementation, a lot of the newer counties like Santa Cruz, San Bernardino are asking the legacy counties like Alameda and LA, how did you deal with documentation? How did you track certain things? What systems did you set up to enroll people quickly and to assign them to medical homes? So there's a lot of that conversation going on in terms of just implementing enrollment and eligibility strategies, and then it'll eventually move on to delivery system change. And so UCLA and UC Berkeley will be coming out with a series of policy briefs over the next couple of years around those issues to inform the public about what's going on, but also to help new counties that are coming along and implementing over the span of the program to learn from each other and perfect their programs a little bit more prior to 2014.
Thank you. And Michael would like to get your thoughts on the following topic. He says, with substance use disorder treatment specifically excluded from the 1115 waiver and the state alcohol and drug program department targeted for dismantling by the governor, it seems we are set to have a huge driver of healthcare costs. Hold on. That is required by federal parity law to be covered in the expansion population, have no preparatory efforts whatsoever by the state. What are your thoughts?
Right. I mean, I think that it's certainly an issue with ADP losing funding and kind of moving into DHCS. I think in 2014 it'll be dealt with because it would be a benefit for the Medicaid expansion population. But right now, in the counties, it's a difficult situation because of the fact that the waiver has already been agreed to. It was explicitly left out. And so what we are going to end up seeing is probably people who have limitations in ADP coverage who are uninsured and in low-income health programs, and they'll be getting their services through departments of mental health and other safety net style clinics, some of it unreimbursed. And so it'll be, really the issue will be coordination of care between those entities, and unfortunately that's something that every county is going to have to deal with separately. I mean, there may be some best practices that we learn over the years and they're able to integrate better based on other experiences, but it's really going to be dealt with at a county level, so you're likely to see differential access at the county level. A similar thing happened that actually did get included in the waiver, which was to require these LIP programs to cover Ryan White drug spending for the HIV/AIDS population who's not eligible for Medi-Cal. So no longer will Ryan White cover the uninsured who are in LIP or in the HCCI programs. Instead, LIP will have to cover that, and a lot of the counties have been scrambling to make sure that they have the funding to do that. And it actually resulted in a decrease of people who were made eligible for LIP because a lot of the counties had to scramble and cut their eligibility criteria because they realized, our spending could be quite a bit higher because of the drug spending that would be required through covering that Ryan White population that they thought had been taken care of through other programs. I'm not sure I hear Karen.
Excuse me. So there's another question from Helen. The variable design of the CCS pilots has the potential for undermining what can be learned from those approaches. Is there a rational strategy for evaluating these pilots?
Well, I would like to think there's a rational strategy for evaluating these pilots because UCLA is working with the state to develop an evaluation design plan currently. I think you're right that it'll be very hard to do head-to-head comparisons between the pilots versus other pilots. So we won't be able to say that ACOs worked well versus EPCCM models, but we will be able to say that the ACO strategy may have worked better than the previous strategy. So I think, again, to reflect on previous questions, it seems like, similar to LIP, that all the counties are very different because the pilots are very different, and there's probably not a great way to deal with it and to create an adequate control group that'll deal with all of the different elements and enable you to control for differences between counties. You can develop a control group to deal with differences within the county and possibly grab comparable populations from other counties that aren't part of the pilot. So it'll be more of a no intervention versus any intervention approach, comparing pilots to previous efforts or pilots to other comparable areas rather than being able to compare the pilots to each other. But we certainly want to engage in this learning process where counties will be able to, or the sites will be able to share lessons learned in terms of how they ran their program, and you will probably be able to do pretty robust evaluation of the programs themselves, but they may not be able to be compared against each other.
Thank you. It looks as if there are no more questions from our participants. Would you like to add anything?
No, thanks for listening, and I hope if any of you have any questions, feel free to contact me directly. My email address is droby@ucla.edu, and you can find my information on the Center for Health Policy Research's website.
Thank you to all the participants for joining us. We will continue the conversation on Wednesday, April 18th with Dr. John Clements, as he will talk to us about global control of cholera. We hope you can join us. Have a great day.